Yes, it's a real pleasure and an honor for me to welcome you here for this first plenary session of Escheide, which will focus on prevention, as Pamela has said. If you remember, most of you who were perhaps in Barcelona, we also started with a session on prevention in Barcelona. And I think this really reflects that we recognize the crucial role of prevention and health promotion when dealing with infectious diseases. The proverb says prevention is better than cure. Is it really always so? And if so, why do we continuously invest so little as individuals and health professionals and policymakers in promoting health and in preventing diseases, and so much more on treating illnesses? So in this session, we want to explore all the challenges we meet when we try to promote a preventive approach, and also see how we can explore how we can demonstrate the advantages of such an approach and convince people also to adhere to it. For this, we need to know why and how people make choices about health. People meaning individuals, but also health professionals and policymakers. And much can be learned actually from other fields, not infectious diseases, but even outside the medical field. And there are many successful approaches, but also failures, and all of them have important lessons for us. So we are very happy to have a very knowledgeable expert in this field with a very broad experience on the matter. And I would like to hand over to Kateřina, who is going to introduce our keynote speaker for this session. Kateřina, for you.
Thank you, Jet. Dear all, please let me welcome the Plenary A keynote speaker, Chris Dye, Professor of Epidemiology at Oxford University and a Fellow of the UK Royal Society and Academy of Medical Sciences. With a rich background in public health and career at the WHO, where he pioneered data-driven strategies to tackle global threats like tuberculosis, malaria, and Ebola, Chris brings profound insights into disease prevention and global health. His latest book, Investing in Health and Wellbeing, When Prevention is Better Than Cure, published in 2024, explores the critical role of prevention in public health. And we are delighted to have him with us today and look forward to his inspiring insights.
Thank you, Kateřina. So, Chris, please, the floor is yours.
Thanks. Thank you very much. Thanks very much, Jet and Kateřina, for that introduction, and thank you for the invitation. It's really great to be here. Prevention is better than cure. That must be true because we've been saying it for 2,000 years. That's just the documented bit, and we've probably been saying it for longer than that. But to repeat Jet's question, if prevention is better than cure, why are we seemingly so reluctant to invest in good health and so willing to spend a lot of money on treating sick people? That's a question that's bothered me for many, many years and in many different ways. Here's one particular example. The scene on the left, this is a story about sanitation, the long history of sanitation. It's a story about how we've basically known how to do sanitation for a long time. The picture on the left is an archaeological site in the Indus Valley. It's an excavation of a site from 2000 BC, so 4,000 years ago, and it's an excavation of a site that shows that there, those people who lived there at the time knew how to build toilets for individuals, communal toilets, they knew how to provide water supplies, and they knew how to provide communal sanitation. They solved the problem technically at an individual level and at a community level too. 4,000 years later, on the right-hand side, is a nearby site in modern-day India with two children openly defecating without any access to safe sanitation. How can it be, 4,000 years after Harappa, that we still don't know or we're still not able to do safe sanitation. And it's not just this example. As the slide says at the top here, there are still more than 3 billion people out of 8 billion in the world that don't have access to what we call safely managed sanitation. And the consequences of that are more than 1 million preventable deaths each year. So that's the problem that I want to address. What might be the solution? Well, in a nutshell, the solution has been given many, many times, but I picked this one particular example from a landmark report that was produced in the UK, now 20 years old. It's the 20th anniversary this year of securing good health for the whole population, a report that was led by Derek Wanless. And the most important sentence in that report is here: a rebalancing of policy away from health care to health will not happen until there is a realignment of incentives in the system. So that's the most important sentence in the report, and the most important word is incentives, and I'm going to repeat that word several times in my own presentation. But what would incentives look like for better prevention? Well, here's my basic idea, and the idea is pretty simple. It just says that if we're thinking about what might happen to us in the future, the threat that might confront us in the future, we're going to consider how big that threat is and how much it will cost us to remove it. If the threat's very large and the cost is very low, then we have an incentive to take action. We're likely to take action. So what does a large threat consist of? I think we've got to ask ourselves 3 questions. First of all, what's the nature of the hazard that we think we might confront? Is it something like Ebola, for example, where the case fatality rate is about 50% in people who are untreated? Or is it something like COVID, where the case fatality is less than 1%, although many, many more people will be infected in a population? So how nasty is the hazard? That's question 1. The second question is, how likely is it to happen? It could be really nasty, but if we don't think it's going to happen, we're not going to worry about it very much. And if it does happen, and this is the third question, when is it likely to happen? If it's going to happen today or tomorrow, we're going to be more worried about it than if it happens several weeks or months down the line. And that's because we discount the future, the value of the future, and I think actually we heavily discount the value of the future. So if you have a high-value hazard, it's very likely to happen, and it's going to happen soon, and it doesn't cost very much to remove it, then that is a set of incentives for action. Cost, incidentally, is not just about money. It's about effort, willpower, information, inclination, and a collection of other things that people use to judge what it will cost them to take action. And on the threat side, the threat is not just about facts and epidemiology. It's also about perceptions of hazard. It's about the values that are associated with those perceptions. And these are themes that I'm going to come back to repeatedly in this presentation. So what we want to do is something like what I've put on the bottom of this picture: consider the health gains in relation to the potential cost. And we're probably going to compare it with other alternatives. Most of the decisions we make are essentially comparative decisions. So that's the general framework, but I want to unpack it a little bit before getting to the question that I posed in the title about cancer, crime, and climate change. 3 or 4 points of unpacking. First of all, you often hear the phrase, the paradox of prevention. And the paradox is essentially the question that Yet identified in the introduction. Prevention seems to be the right thing to do, but we don't do it. So that's a paradox. It's apparently irrational. But the irrationality, in my view, is usually quite superficial. Once you dig a little bit behind the way in which people make decisions, you find out what the reasons for those decisions are, what the explanations are for the way in which people behave. This is one example I've picked from many. This is about transport. And I chose transport because it's not about infectious diseases. And we're trying to learn lessons about infection from other areas of health. So I've picked transport. The apparent superficial paradox is that the most complex machines that we use for transport turn out to be the safest. So you've got cars on the left, where the number of deaths per passenger miles is very high. And there's a logarithmic scale on the left, by the way. And on the right-hand side, the most complex machines of all that we regularly use are aeroplanes. Per passenger mile, these are data from the United States, it's 500 times safer to travel by aeroplane than it is to travel by car. And yet aeroplanes are clearly difficult things to make. Why is that so? The answer, basically, I think, is that people are really quite frightened of flying. Anytime there's an air crash around the world, anywhere in the world, it's worldwide news. Everybody knows about it, and they know about it instantaneously. I think the problem with air travel is that we feel we have no control over events like we do when we're sitting in a car. And we also know that if there's going to be an accident, it's very likely to be a fatal accident. We're going to lose our lives, and there's nothing we can do about it. The point is, this is not really a paradox of prevention. It's completely explainable once we get to the roots of the behavior that explain why aeroplanes are much safer than cars. The second point that I want to make is about perceptions, values, and vocations, and how we use these in public health. This is a picture of two people who have vocations. Pope Francis, in a conversation with the Director General of WHO, Dr. Tedros, and they're talking about health as a human right. Now, the idea of health as a human right is something that most people in this room will warm to. But there's a lot of people outside this room who are responsible for making decisions about health who are not persuaded by the idea of health as a human right at all. The general question this raises is a really important one and a really neglected one in public health. What kind of argument are we making, and who are we talking to when we make it? Is it an argument about facts and logic? That's very familiar to everybody here. Is it an argument about moral sentiment? That's the point about vocations. Or is it an argument that comes simply from authority? Those are the three standard pillars of rhetoric, and we need to consider more regularly, I think, which kind of argument we're making and who are we making that argument to. There's an important consequence as well for public health, where we very much like the idea of standardization. I used to work for the World Health Organization, where standardization was part of our everyday business. We like to produce recipes that can be used around the world. But the important point about behavior in the context of public health is that it's often local. And we need to investigate what the basis is locally for why people make particular decisions. The last introductory point I want to make is about how much we really spend on prevention. You'll commonly hear it said, particularly in the context of health services, that we spend very little on prevention, far too little on prevention. And here's data from the WHO database. On the bottom axis, each point, by the way, is a country. On the bottom axis, you have total health expenditure in dollars per capita. So the ones from about the middle of the axis over to the right-hand side are middle and high-income countries. On the vertical axis is the proportion of all money spent on health that is spent on prevention. What you see is that in middle and high-income countries, mostly they spend less than 5% of all money spent on health. Within the health system, less than 5% is spent on prevention. Now, these data come from the International System of Health Accounts, which is a really beautiful way of counting how much money is spent on health. but it has a major limitation for the discussion we're having today. And the limitation is that it only counts money that is spent directly on health within health services. But of course, much more money is spent on prevention outside. We don't know how much because there isn't an accounting system, but here's a way of approaching the problem. In this graph, I've plotted on the horizontal axis the change in mortality rate against the change in the vertical axis in incidence rate. Now, if we're considering a condition where the reduction in mortality is entirely attributable to the reduction in incidence, then it will lie on that diagonal line. That's a case of pure prevention. If we're considering a condition where the reduction in mortality is accompanied by no change in incidence, then it will lie on the horizontal line. And that is a reduction in mortality that's entirely due to a curative process, something that happens between incidence and death. That's the framework. Where do the data tell us that we sit? Well, this is all the data that are gathered actually by the Global Burden of Disease project, and that's the only project from which you can do this calculation. And the result is interesting, I think. It's somewhat expected, but it's also interesting. On the diagonal, the pure prevention line, what we see is by and large vaccine-preventable diseases. Bottom left are the best performers, yeah? Biggest reduction in mortality, biggest reduction in incidence. That's measles, tetanus, diphtheria, and then a little bit further up, we have yellow fever, rabies, typhoid, whooping cough, and one or two others. So vaccination, and Pamela emphasized this in her introduction, of course, vaccination is a crucial part of prevention, and it contributes a lot to the idea of pure prevention on this graph. What is pure cure on this graph, if you like? What are the conditions that lie on the horizontal axis? Well, those two are expected. They are all diarrheal diseases, for example. We have some vaccines against diarrheal diseases, but diarrhea is caused by lots of different kinds of infections. Saving lives is mostly about curing people who have already been infected. The same is true for upper respiratory infections as well. The same is true for a different set of conditions, congenital malformations, those that we inherit from our parents. And there are a number of other examples that you can ponder on this graph as well. The key point, the details are interesting, but the key point is that whereas the system of health accounts says that we only spend 5% or less within health services, if you take the weighted average of all of these data, it's about 50% reduction in mortality is attributable to reduction in incidence. In other words, we do much better on prevention than the SHA statistics suggest. And also, what's important for us as a public health community, that a lot of prevention happens outside health services. And that's a strong message from that, is that we need to work more effectively, or very effectively, or even more effectively, with other sectors in the population. So that was the introductory part, and all of that I've written down in a book that I recently published. On the left-hand side is the first edition that I wrote during the COVID pandemic. And some people said once I wrote it and published it that, even some people quite close to me, that no one's going to read that, it's far too brown. So I wrote a red version of the book instead, hoping to attract attention in bookshops. Actually, it's already free online, this book. I raised a grant so that we could publish it open access, and Oxford University Press, the publisher, tells me that it will be online tomorrow, the open access version. So, you can... Great, so you can buy it if you like. If you want the hard copy, you can buy it. Or you can just read it online. Now, that was the half-time announcement, if you like. Now, I want to get to the title of the talk. What's all this got to do with cancer, crime, and climate change? I want to give you 3 paired examples, and I'm grateful again to Jet and Kateřina for stimulating me to do this, because I hadn't thought about it in these terms. But this is what I'm going to try and do for the rest of the talk. First of all, cancer paired with pandemics, and in particular, tobacco paired with Ebola and somewhat COVID as well. What have they got to do with each other? Well, the hint comes in that quotation at the bottom here, which is also in the book, from Thomas Adam, who once remarked that hell is truth seen too late. Now, Adam was a religious man, and when he spoke about hell, he meant hell. But it's actually an apt metaphor for public health, because a lot of the difficulties that we face because we delay too long in taking action about an accelerating threat. So here are the data, and I've plotted the consequences of tobacco smoking on the left for death, the consequences of Ebola on the right for a growing pandemic that turned out to be the huge West African pandemic of 2014-15 mainly, with which I was closely involved in WHO. And you can see the similarities in the 2 curves. If you're a young adult smoker, you don't think about the health consequences of smoking some way down the line. You don't think about dying of lung cancer 20 years later. You just think about enjoying the next cigarette, which isn't going to kill you. On the right-hand side, with respect to Ebola, we knew that there were cases of Ebola in West Africa, and it was bubbling along very gently, but what was going to happen? We didn't anticipate, and therefore we didn't take action. We didn't anticipate that huge pandemic that happened within months of making those first observations. What we need as a solution under these circumstances is the same for tobacco and for pandemics. We need a way of intervening early. How can we shift the incentives, that keyword incentives again, in order to make that happen? Well, I'll talk to you about 2 different forms of collective action that work in both. They work partially in both instances. First of all, tobacco. We know that people are very sensitive to the price of cigarettes. So if you push up price, people will stop smoking. The graph on the left-hand side shows that smoking rates for France are essentially the mirror image of price. When you push up the price, smoking rates go down. That's good for public health, it's good for smokers, and it's good for governments because they raise tax revenue that comes from that. But it does only work up to a point, and we need to be aware of that. The problem with taxation, not just for cigarettes, but for unhealthy foods or anything else that we want to use it for, is that it can only work up to a point in terms of raising revenue. Because if the price goes too high and everybody stops smoking, well, marvelous for public health, but the government raises no money and they're going to stop doing it. So governments will be inclined to tax at intermediate rates, not high rates. The second limitation is on the right-hand side here, which is the relationship between deprivation or social and economic disadvantage and smoking rates. So we know that when you put the price up, smoking rates come down. But the paradox here is that poorer people smoke more than richer people. So price can only be a deterrent up to a point. So why do people smoke more than richer people, even though it costs them a larger proportion of their income? Well, I have some ideas. We can discuss it later. I won't go into all of the possibilities, but it's an obvious fact of life that poorer people tend to smoke more. So the price, the taxation mechanism can only work up to a point. How would we apply similar ideas in public health? What kind of collective action could we take? Well, we thought about this during Ebola a lot, but it applies to every pandemic since. What we need is a device that gives people benefits right now. We don't say to people, in other words, you have to do something because something nasty will happen in the future. It's not a compelling argument because as I said earlier on, people heavily devalue the future. And they also throw a bit of uncertainty into that as well. If we want a mechanism that works now, it has to be a mechanism that gives advantages now or works as a deterrent in the case of taxation. But this is an example which is underplayed. It was certainly underplayed in the UK during the COVID pandemic, which gives advantages now and advantages later. And that is to have a fully functioning public health laboratory service which routinely delivers benefits for public health, but which has surge capacity in case of emergency. I've quoted in the middle of this slide actually a very nice article that was written by some colleagues at McKinsey during the Ebola pandemic. They said very rightly, what we don't need are systems that are essentially break glass in case of emergency. What we need are systems that are always on. When they're always on, we know they function properly. If we give them surge capacity too, then they could provide a rapid response during pandemics or epidemics. My second example, this is the crime example, is about guns, essentially, and tuberculosis. So what do guns and tuberculosis have in common? What they have in common, which is misunderstood, I think, by many public health authorities, and with all due respect to the TB Alliance, which does great work, statistics like this, TB's killing someone every 20 seconds, have almost no traction whatsoever. What has traction for low-value hazards that kill many people are when things happen suddenly, unexpectedly, and to people who we think are important in our communities. So let's look at guns in the United States. The events that attract attention are so-called mass shootings, and that is when 4 or more people are killed or seriously injured. In 2023, 655 people lost their lives through mass shootings in the United States, and all of them were made very public in the way that this happened with this picture here. This is actually the Sandy Hook shooting, which was back in 2012, that happened in Connecticut, where 20 school children were killed by a gunman. But only 655 people died in mass shootings. The total number of people who died at the hands of guns in 2023 were 43,000 people. In other words, somebody dies from a gunshot wound in the United States every 10 minutes. But that never makes the news, because that's what happens routinely. What do we do with these observations? Well, what I think we can do is that we can use these unusual events that attract a high level of attention to get people to think about the broader problem. Here's one kind of analysis of gun control in the United States, just one, there's lots of them. This is the way in which support for gun control increased according to how many people were killed in a particular incident. And the points that I've circled essentially show you that it's mass shootings that attract attention. And once attention has been attracted, then support for gun control goes up dramatically. The bad news is that it actually wanes quite quickly, and that's the circle on the right-hand side of this picture. So the question arises, how can we maintain support for that? And of course, now we're going to have a change of president in the United States. That's become a huge question. And I wouldn't like to predict where gun control is going to go next, because I think there are forces in both directions. That's something we can also discuss later on if you'd like to. But I want to ask the question what that's got to do with tuberculosis, because you're mostly interested in infectious diseases. And as I was thinking about what to say about this, I came across this headline a couple of weeks ago in the New York Times. John Green is a popular novelist in the United States. He sells many, many books. He has recently discovered tuberculosis and what he calls the empathy gap. In other words, in low and middle income countries where most tuberculosis still is today, there's plenty of TB, but not very many people care about it. And people don't care much about it in the rich world either. by trying to fill the empathy gap, as he calls it, he might make some progress, but frankly, I'm not particularly hopeful. Well, his books sell lots of copies. He'll certainly sell more copies than my book, that's for sure. So he might be onto something. But what really counts in tuberculosis is what counts in gun control. When you have a sudden, rare, and unpredictable event, people sit up and take notice. So this is one that's been familiar to us who've worked in TB for years and years, and it happened under Republican President Ronald Reagan during the 1980s. Of course, he said when he came to office, I'm going to cut taxes, and what he also meant was I'm going to cut public services as well. The consequence of him doing that was that this long-term decline in tuberculosis that you see on the left in the United States suddenly stopped, having taken away the money from TB control. It stopped and it was reversed, and I've expanded that decline, that halting and reversal in the inset at the top center of this slide. And this quickly became called the U-shaped curve of concern. It was widely advertised as that, and people eventually sat up and took notice. In the grand scheme of things for tuberculosis, it was actually only a small uptick in TB control, but it really got a lot of people very worried. And when Reagan left office, he was succeeded by George Bush Sr., who started to put money back into public health services, and who was then followed by Bill Clinton, a Democrat, who put more money back into public health services. And the consequence of that is the series of points that you see on this slide. Even today, the consequence of that uptick is probably, I reckon, still being seen in the United States, because for tuberculosis, which moves rather slowly through populations, gains take a long time to make, but they're very quickly lost if you take your foot off the pedal. And that's what happened during that U-shaped curve of concern. So the U-shaped curve of concern is like a mass shooting. It draws attention to a significant event, an unexpected event with unexpected consequences. There's one more example for TB I'll give before moving on to the next. And this is one that we were involved in Southern Africa. It was the emergence of what came to be called XDR TB. And those of you who've worked with tuberculosis will know all about this. XDR stood for extensively drug-resistant TB. And the X was convenient because X is easily the most frightening letter in the alphabet. And if you call something XDR, people do sit up and take notice. But what happened at a place called Tugela Ferry, and Tugela, as it happens, stands for, in a local Zulu language, for something that startles. It was a startling event. Extensively drug-resistant TB got into a hospital ward full of HIV patients. It infected all of those patients, and it killed all of them within the space of about 2 weeks. That sent shockwaves not just through the community in South Africa, but much more widely, and it drew broad attention to the problem of drug-resistant tuberculosis. So it was an unusual event that had a large benefit for TB control. But as with gun control, the problem is to maintain that level of interest. Let me move on to my third example, climate and sanitation. And sanitation will take me back to where I began this presentation. The link between climate and sanitation I'm thinking of is not the obvious link that you see on this slide. Climate change causes more flooding, and more flooding wrecks sanitation systems. That's true, but it's not the point I want to make. The point I want to make is that bigger point that I showed you on an earlier graph, where I said that a lot of prevention comes from outside the health services. And being outside the health services, it means that health has got to be put in that broader context if we want to have leverage, if we want to gain traction. This is just one example of the kind of argument that has been used to get some traction. It's the so-called co-benefits argument. That is, if you do things for climate change, they're also good for health as well. And that works partly. Like taxation for tobacco, it's an argument that works, but only in part. This is the story, slightly complicated slide, but actually it's quite a simple story. This is the story of the elimination of coal from the UK, which took more than a century to achieve, and the last coal-fired power station was closed about 3 weeks ago in the UK. The declining blue line is the decline of coal. The dotted line that goes very closely alongside it is the reduction in sulfur dioxide pollution. That's great for health, but those two things together didn't have any effect on carbon dioxide production, which is the green line at the top of the slide. And that's because coal has been replaced by gas, another fossil fuel, and the only way that we'll really get those co-benefits is by switching out of fossil fuels altogether, with the health benefits that go along with that, and into renewable energy. And you see that the rise of renewables has coincided in the UK with a decline in greenhouse gas emissions. So the co-benefits argument works, but it only works up to a point. It has to be calibrated locally. There are lots of other arguments that could actually, I think, work better than we've made them to work so far. And one of the ones that I like and have described in the book, partly because I've rarely seen it discussed in the health community, and that is the social cost of carbon. It's a metric that's used widely in the United States, and it's linked to the regulation of greenhouse gas production by electricity utilities, electricity companies. The social cost of carbon includes four main elements which are to do with agriculture, energy, health, which is represented by mortality, and environment, which is represented by sea level rise. So it's actually quite a crude index, but it really works because the social cost of carbon influences the credits that can be given to electricity companies for not burning fossil fuels to produce energy. In other words, in some localities in the United States, it's an incentive for nuclear power instead of power based on fossil fuel energy. I think it needs developing more. I think the health community could play a role in putting health in that larger context of the social cost of carbon. How does that relate to sanitation? Well, the argument for sanitation in the public health community has very often dwelled upon the nature of technical sanitary facilities. So how you build an efficient toilet, how you build an efficient toilet cheaply. But we know from looking at what happens on the ground that efficient toilets don't make people on their own use sanitary systems more effectively. The kind of thing that really works is illustrated in this very nice example. There are lots of examples, but I really like this one. It comes from Maputo in Mozambique, where they compared the local population response to pit latrines. That was the standard, essentially just a pit into which you defecate, no covering, no soak away, no sewerage system associated with it, with an advanced pore flush toilet. And they measured the benefits perceived by the community in terms of what they call the Sanitation Quality of Life Index. And that Quality of Life Index has health in it, but it has other important ingredients. And they're important because these are the ways in which people make decisions about whether they're going to use the toilet or not. Disgust, privacy, health, shame, and I would add safety from other settings that I've seen as well. You can see that for pore flush toilets, the dark blue bars, the Quality of Life Index was way higher than it was for the primitive pit latrines. The consequence of that is that people are much more likely to use them. So we need to put health in that broader context if we're going to succeed. So this is my last slide, in which is a brief summary of what I've said in the two parts of the talk. First of all, the title of the talk was "What Can We Learn from Cancer, Crime and Climate Change?" But it will have become obvious to you that the learning goes in both directions. And that's the beauty, I think, of talking about the underlying general principles rather than focusing on specific diseases. The second point is that the choices people make, they are somewhat to do with facts, but they are a lot to do with perceptions and values. And we need to understand what those perceptions and values are and take them seriously. And this echoes what Pamela had said in her introduction. Unless we understand how people really make choices about health, then we're not in a position to set incentives for shifting away from curative treatment and towards preventive treatment. And then in the second part, I gave 3 paired examples which focused on how we can get people to think today about the future by giving them incentives to do so. How we can get old and familiar hazards that are neglected to make the news, as it were. And finally, how we can put health in the broader context of well-being. Thanks very much for listening.
Please sit down.
Thanks.
Well, thank you very much, Chris, for a very, very inspiring talk. And I'm sure there will be many questions from the audience, but before we move to those questions, we would like to ask 2 questions to you, just to have a view of how you look against prevention versus cure. So if you can all take your phones and go to slido.com and look at the first question. I will give you 1 minute to give a reply. You just have to make a short selection. Is prevention better than cure? Yes, most of the time. It depends, or no, often not. We can see how many have answered.
Ah.
Up there, 87, 104.
Work out the Can you tell when you have enough answers?
Yes, we have quite a lot of answers. There's still answers coming in, but I suggest we'll take a look at the results. Can we display the results, please? Yes. Is prevention better than cure? Yes, most of the time. You've been very convincing. Chris, would you like to briefly comment on this?
Well, that's a fascinating result, actually, that prevention is better than cure most of the time. I mean, I would agree with that, but I would also make the case for it depends as well, because that was the essence of much of what I said in my talk. Prevention can be better than cure, provided we get the incentives right. So that's the it depends part of the answer. So I think if I was answering this question, I would say it depends.
Okay, let's look at the second question. We have a second poll question for you. And the second question will be, if you get there, where does the primary responsibility for prevention lie? The primary, the most important. With the individual or with collective, it is the collective responsibility via public health services and other administrations. We'll go to 500 replies. Yes.
Where are you looking?
Okay. I think we have quite some replies in there already. So can we display the results? Okay. Primary responsibility. Mostly of you think it's it's a collective responsibility, not just the individual. Did you expect this reply, Chris?
From this audience, yes. And the reason is that as people who work in public health generally, we believe in collective responsibility. But it's a very politically charged question, of course. And what we're seeing all over Europe and more widely at the moment is a move towards the right in politics, where many of those who are gaining power would not answer the question in the same way. They'd place the responsibility with the individual. You hear pejorative terms that are widely used in English, such as, in England anyway, such as the nanny state. That is where people should not be looked after by the state. They should have what some call their freedom to make their own choices. So that's a typical right of centre argument. And I think as a community, one of the arguments that we're going to have to successfully make is the argument for collective responsibility. But in making it, we mustn't assume that the people we're talking to will agree with us a priori. If you're talking to people at coffee, and in this conference, you'll find plenty of people who agree. But we need to be talking to people outside, because they're the ones that are going to be making the decisions. And the question is, how do you effectively make that argument? There's a really nice literature, actually, on this in the United States, of all places, and I've written about some of it in my book, which is essentially, how do you talk to a Democrat and how do you talk to a Republican about public health? You can say the same thing, but you better say it in different ways, because the way you talk to people depends on how they listen to you and how they take you seriously. And that's a skill that I think, emanating from the factual expertise that we have, the scientific expertise that we have, that's a skill that we need to develop in communication.
Very, very well. Good. Thank you very much. I think Kateřina now prepared the questions that came from the audience. So time is getting short, so I propose we move on to those questions. Kateřina, up to you.
Thank you so much. Chris, we received so many wonderful questions, so I selected 2 or 3, so let's get back into it. What would you consider good health as an outcome or as an incentive? Would you consider good health as an outcome or as incentive? Is there any circumstances when health can be considered as an incentive?
Yeah, that's a nice question, actually, and it allows me to emphasize that something that I didn't say enough about in the presentation, which is that, and that's because of the way we frame the argument about prevention. Prevention is about stopping something bad happening to us. But investors, someone who is used to investing not in health but in anything, will think about not just avoiding the pitfalls, avoiding failure, prevention, but also investing in a positive asset, something which will grow and give productive rewards. And that's essentially what health will do. And in some instances, people have investigated the balance between investing in something that protects you from illness versus investing in something that will actually improve your health. Status quo, but getting better. The argument for better health is actually quite a hard one to make. It's been explored with respect to developing healthier foods, making the argument not only that if you eat healthier foods, you won't get sick, but also your physical well-being will also generally improve. But the argument for better health, as opposed to protecting illness, is a difficult one to make. And from a scientific perspective, I think it's an underexplored question too.
Thank you so much. So how can we address the inherent economic challenge that prevention strategies often appear less profitable than curative interventions? And what role should governments, public health institutions, and private sectors play in rebalancing this dynamic to prioritize long-term public health benefits?
Well, the answer is the whole book that I wrote, actually. But it's a nice question because it allows me perhaps to mention a couple of things. I mean, basically, what I'm talking about is economics, but I'm not calling it that. I think at least up front. I think health economics needs to reflect a little bit on how it does its business, because in many ways it's too constrained around the points of understanding how people make choices. The study of health economics should be about how people make choices, but very often it neglects local details about how people perceive threats to their health, how they perceive advantages to their health, for example, in eating better foods. And because it neglects those things, I think it gets the wrong answer to the question. And what you get as a consequence of that is what one thing that Pamela alluded to in her introduction, is that you get the finger wagging from the health economists who say, you need to do this. Well, people don't respond well to that, especially if they have good reasons for not doing it. Then the argument doesn't actually work. So that's one particular point. The other key point in the question, I think, Kateřina, is something I also didn't emphasize, which is any health decision involves a diversity of different people. But again, health economics in its simplest form, and rather the way I presented it in this talk, is usually thinking about one kind of provider and one kind of consumer. And it's done like that because it's mostly talking to national health services providing a service for the population. But what we need is a much broader form of health economics, which takes into account the interactions between different entities. So you have the people themselves whose health we're concerned about. You have commerce, industry, NGOs, governments, and all the other players. And you need to know, when decisions are being made, how all of these entities interact with one another, what they're trying to do, and who has the power, importantly, to make decisions. The power is a really important question.
Thank you. Thank you so much, Chris. And one last question, a very brief one. Are there initiatives to standardize the way prevention investment data is collected or should be evaluated?
Well, I think there are many forms of standardization which are very useful within health services about prevention. Where it gets difficult, I think, is when we go broader than that, and I think that's where there's an opportunity for the health community to go outside and talk to other people and do the necessary negotiations about how those metrics are developed and how they are used. The virtues of doing that I tried to indicate, for example, around the idea of the social cost of carbon. That's an area where government has taken the lead, if you like, by saying, if we're going to have a social cost, we need something to do with health in there, but let's put that in rather crudely and then see what happens. But it actually affects the way people make decisions because there's lots of money associated with it. So as a health community, we need to look around at metrics like that and ask, where are our opportunities to have that extra leverage?
Okay.
Thank you very much,
so much, Chris.
I'm so sorry, time is so short, but we will have to respect the time schedule. So, Kateřina, please, you could give some final remarks and closure remarks, please.
Thank you all for your active participation today throughout and thought-provoking questions throughout the plenary. As we wrap up, let's reflect on a key takeaway here. While prevention is often recognized as better than cure, the true challenge lies in giving it the priority it deserves, both collectively and individually. How can we overcome the barriers to making prevention a fundamental pillar of global health strategies? Chris has drawn on powerful lessons from successes and failures in diverse fields such as cancer, crime, and climate change, challenging us to rethink the balance between prevention and cure. His insights into how these lessons can be applied to infectious diseases provide a compelling case for shifting focus while learning from past achievements and missteps. And we encourage you to continue this important conversation with Chris later today. He's eager to hear your thoughts and explore ideas together. Thank you once again for being part of the discussion, and we hope it inspires you to drive meaningful change in your work and beyond.
Thank you very much.
Good, thank you. Thank you.